So my name is Emma. I am a third-year medical student at Burrell College of Osteopathic Medicine in New Mexico. I've had the pleasure of talking with you guys a few times before. To those of you that are coming back to visit us again this round, thank you very much. For those of you that are new, welcome. Today we're going to talk about something that maybe is a little bit out of my wheelhouse. I like internal medicine topics. We're going to talk about postpartum hemorrhage. I'm currently in my OBGYN rotation now, and postpartum hemorrhage is a very big and serious topic for OBGYN, for obstetrics and gynecology. Okay, so without further ado, let's get started here. All right, so like last time I talked to you guys, I do have a book for you guys to check out. This is a book, it's a really good book too. I read it pretty quickly. It's about a physician of whom had terminal lung cancer, started writing this book, and then his wife ended up publishing it sort of on his behalf. I do recommend it. It talks a lot about illness and kind of how patients react in the face of illness. And he kind of, was a physician of whom experienced that firsthand. So if you haven't read this book, I recommend it. I know some of you guys don't have a tremendous amount of time that you're also applying to medical school or in college or whatever, but if you need something to put on your nightstand, this might be a good one for you. Okay, so we are going to talk about postpartum hemorrhage today. And I do have one question to throw your way initially. So let me throw this one at you real quick. Like the last couple of times, I'd like to ask you in the beginning how much you know about the topic, so we can kind of, tailor the talk to you. Okay, we have a few more out there. All right, I'll stop it there. Okay, so you guys, for the most part, kind of said, I know nothing and I know a little, which is perfectly okay. When I was in your shoes a billion years ago, I don't think I knew anything about postpartum hemorrhage either. So that's exactly what this is for, to teach you a little bit. We're going to keep it simple. I don't want to confuse you guys or sort of inundate you with a lot of information. We're going to try to keep it simple and hopefully teach you guys something today, okay? And I hope you guys appreciated the meme on the right. I hope you guys watch Bob's Burgers. I love that show. I got into it like last year, but hopefully you guys understand that joke. Yes, Stephanie, it is fantastic. Okay. So as always, what we're going to do is we're going to go through a case. We're going to kind of present a physical exam. We're going to go through differential diagnoses, and then we'll walk through the assessment and plan, as well as sort of a little lesson on the pathology of postpartum hemorrhage. For you guys, your role, like the last few times, we want you to actively participate. If you have questions, ask them. We're happy to answer any questions that you guys have. And then for credit for the session, we ask that you fill out the SOAP note. And as kind of a quick reminder here, the SOAP note is, it is spelled like soap. And it's for subjective, objective, assessment, and plan. So we're going to go through all of these things. The subjective information is the information that the patient's telling you. The objective information is the information that we find, whether that's a physical exam or the vital signs. And then the assessment is what we think, and that's going to kind of make up our differential diagnoses. And then our plan is what we're going to do based off of our differentials and what we think the pathology is. So we'll kind of go through that. If you have any questions about that, just let me know, okay? All right, and here's kind of that form. Becca has put it in the chat, and we can certainly put it out there again for those of you that logged in afterwards. But just fill it in to the best of your ability. We're not looking for, you know, super stellar, you know, level 5 SOAP notes. So, you know, do your best, kind of fill out the information and kind of be like a sponge and take it all in, okay? Okay, let's get started with the case. So a 27-year-old G3P2 female, and before I go on, I'll explain what that is. G stands for gravida, P stands for para, and A stands for abortions. So for this woman that we see in front of us today, what we see is that she has been pregnant 3 times. She has given birth twice. So basically, we know that she is pregnant now, even if we just had that information. So she is currently at 39 weeks gestation, and she's presenting to L&D with new onset contractions. Hold on, my computer kind of just froze here. Perfect timing. All right, sorry about that, guys. So this is a she's presenting at 39 weeks gestation to the L&D department with new onset contractions. The patient received regular routine prenatal care throughout her pregnancy. This pregnancy was complicated by polyhydramnios and gestational diabetes, which was diagnosed in the 25th week and controlled with insulin. The labor was augmented with oxytocin, which is a medicine to kind of help with contractions. Delivery proceeded rapidly and resulted in a healthy 4,600 gram baby. This is 10 pounds, 2 ounces. The placenta was delivered in its entirety with normal vascularity. The estimated blood loss was approximately 900 milliliters. Following delivery, the patient appeared lethargic, difficult to arouse, and experienced one isolated syncopal episode. So to answer the question that was just put in the chat, it does include the current pregnancy. And there's another system that sometimes OBGYNs use, GPA-T-PAL or GT-PAL. And it kind of depends on the preference, but this does include the current pregnancy, because as you can see, gravida means how many times she's been pregnant, and then P is the number of times of which she's given birth. The only other way that we can get gravida, the number of times she's been pregnant, with P is adding the A at the end, the GPA. The A stands for abortion, so losses of a fetus before 20 weeks gestation. And if she had G3P2A1, then that would mean that she's not pregnant now, but it does include that. Okay. So let's go ahead and move on and sort of take into consideration other things here. Let me clear all that. All right, so questions we want to consider here. What are important differential diagnoses that we want to consider here, given kind of how she's presenting? She just gave birth. We know that she could have lost a lot of blood. Did she lose a lot of blood? Does anybody know? Yep. Okay, good. Does anybody cutoff is for at this point for normally 400? Very close. So we know that she is given birth vaginally. The cutoff for vaginal delivery is 500 milliliters. For C-section, we want to consider about 1,000 cc's, 1,000 milliliters. But some sources will tell you 1,000 milliliters regardless of the source. Okay, so it's usually so, and it's kind of tough. It's a lot of it is estimated blood loss. Based on, what lap pads, based on, the physician's, judgment, based on what has been suctioned. So a lot of times it's, there can be a margin of error, but a lot of times it's estimated. Okay, so in terms of differential diagnoses, what do we want to consider here? Do you guys have ideas? And then the other thing is shock. Good. Yeah, we certainly want to consider shock in somebody of whom has lost a lot of blood. That's great, Josh. And then my second question, if you guys are unsure at this point of what differential diagnoses, which is totally okay. Postpartum anemia, yeah, Valerie, you could be absolutely right. Losing a lot of blood can lead to an anemic state and correspondingly sort of consequences associated with it. And if you guys went to my talk about anemia last time, you might see some things kind of parallel between the two things. So I think, the anemia talk before set you up perfectly for this one, okay? And then what things are of the utmost importance? What did we learn about the vignette that is important? She had gestational diabetes. Good. Yeah. She had complications with the pregnancy. Good. So we know that she received prenatal care, but we know that she had gestational diabetes. You guys are absolutely right. What other thing? She had a syncopal episode. Yes, that could absolutely be because of the blood loss. There was one other thing that could be because of the gestational diabetes, but could be because of a separate problem. Polyhydramnios, good. And the baby's a bit heavy. Yeah, you're absolutely right. The baby is 4,600 grams, and we call it macrosomic, meaning a large baby once it's greater than 4,500 grams. So that cutoff here is, let's see, 4,500 grams is macrosomia. And then if a baby is little, then we want to call that microsomia. But we don't have that in this case. We have a macrosomic baby, a big baby. Okay. Anything else that we kind of were presented in the vignette that might be of importance? She hadn't had a miscarriage. You might have gotten a little bit tripped up there, Josh, due to the fact that I was kind of giving a hypothetical. So she's pregnant with a current baby. If you remember, she, let's see, was G3P2. I said the only way that we could get G3P2 without her having been pregnant is having an abortion now. But she hasn't had a miscarriage now. So you might have got a little bit tripped up. Sorry if that was a little bit confusing. Oh. Oxytocin, yeah, good job. So you guys might have caught that from going back to the slide here. She did receive oxytocin to augment labor, perfect. And we know that she lost, quite a bit of blood here. And we know that the labor proceeded rapidly. So those are the important things kind of that we're talking about at this point. And then we kind of answered this other part. What about the pregnancy or the birth history is significant? So we talked a little bit about the polyhydramnios, and we talked a little bit about the gestational diabetes. So the gestational diabetes can be a setup for that baby to be macrosomic, to be a big baby, because it's taking in those the excess glucose that the baby is exposed to rather. The other thing is the baby has polyhydramnios, and that was something that I told you could be related to gestational diabetes, but maybe it's not. Maybe it's a different problem. When we think polyhydramnios, there hasn't been sort of this definitive connection with polyhydramnios and gestational diabetes, though there is this connection between the two. A lot of theories are because the baby's kidneys are having to kind of work overtime in order to filter the excess glucose. And then another cause of polyhydramnios can be due to an intestinal atresia. So the baby's not able to kind of swallow the amniotic fluid to make the meconium. And so there's excess fluid in the womb, okay? And what other questions do we want to ask this woman? What do we want to find out? She may not be able to talk to us given her condition being fairly critical. Good. Does she have any coagulation issues? We absolutely want to know something like that as well. So we might look at her chart. We might ask the partner, whatever the case may be. Is this due to amniotic fluid? Yes. So polyhydramnios, sorry for not explaining that before. Polyhydramnios means increased amniotic fluid. If we say oligohydramnios, oligo meaning little, like a little bit, that means too little amniotic fluid. Any medications she might be on? Absolutely. We absolutely want to ask if she's on any medications. Is there a history of difficult pregnancies in the family? Good, yeah, good canon. So I think that is important to ask. And it's also might be a good question to ask her if she had difficulty with any of her last pregnancies. We know that she had 2 other babies. So did she have any difficulties with that then? So the social history, good, yeah. What about the social history, Josh? What do we want to ask specifically in terms of social history? If she exercises, exercise, diet, smoking, good, yeah, that's what I was getting at. If she smokes and drinks, yeah, those can be risk factors for problems with the placenta. History of fainting or syncopal episodes, good, yeah. You guys are elite history takers. You must all be scribes. You guys are great. Okay, and then my last question for you is, what body areas do we want to examine here? What do we want to take a look at? The abdomen, good. We can ultrasound the abdomen, absolutely. Anything else? Uterus, yeah, good, perfect. Yeah, we absolutely want to take a look at the uterus. We know that this woman has given birth vaginally, so we want to check that out and see what's going on. Okay. All right. So I want to give you a little bit of a warning. I have 2 warning slides on this because I don't know if you guys are of faint of heart, if you see blood and you get queasy, but I have added kind of these warnings for you just in case. All right. So in terms of the physical exam, our patient here is, we see that she is hypotensive. That's the first thing we've kind of noticed here. She's hypotensive, she's tachycardic, meaning high heart rate, low blood pressure. In general, she looks a little lethargic, okay? She has dry mucous membrane, so she might be dehydrated. And then if you remember from the anemia talk, having this pallor to the anterior rim might be indicative of anemia, okay? And then the other thing is we hear a murmur on her cardiac exam. Is this related, guys? For those of you that came to the anemia talk, is this related, or is this just could she have had this before? Pallor is paleness. Is the murmur related? What do you guys think? Yeah, good. It is related. Does anybody know why it's related? That's okay. It's a hard one. So, the the murmur can be related because if there's a decreased volume, generally hypovolemia, you can hear increased sounds in the great arteries of the heart, which causes this kind of diastolic murmur associated with anemia. Okay. The only other thing, actually a few other things, was this macrocytic anemia. Hard to tell at this point what type of anemia is. We might have to get, labs like a CBC in order to sort of delineate what it is. It can cause her syncopal episode. Yeah, Emily, you're absolutely right. It can cause her syncopal episode. If we have a problem with the valves, if we have a problem with the heart, this can lead to decreased perfusion to the brain and cause, syncope as a result. And then we see a little bit of diffuse crackles in the lower lobes, which might be indicative of having too much fluid in her lungs, so pulmonary edema. And then the exam that we really wanted to look at was this one. So we used a speculum and we looked into the vagina, looked into the uterus, and we saw lots of blood. We saw diffuse blood with clots present without noticeable lacerations. Why is this part important, guys? This lacerations part. Why do we want to make sure there's no lacerations? Yeah, it begs the question where the blood is coming from. That's absolutely right. A laceration could absolutely be a cause of postpartum hemorrhage. So when we're looking, we want to be thorough and make sure that this is not the source of her bleeding. So we know that there's not a laceration that we've found thus far. And her neuro exam is difficult to obtain. This 2/2 means secondary to. And the AMS means altered mental status, okay? And then the skin, we see no evidence of petechiae or oozing from the IV access site. So why did we want to make sure that isn't happening on the skin? Yes, this is normal, but why did we want to include that in her exam? Good, for platelets. Is there a specific condition that any of you guys can think about for oozing, diffuse bleeding, petechiae on the skin? Von Willebrand's might, yeah, it could, certainly. I'm thinking of one very specifically. You guys are both close. Parab and Josh, you guys are both close. There's one, it's sometimes called a consumptive coagulopathy. Does anybody know what it is? DIC, good job. Exactly. So it's disseminated intravascular coagulation. A lot of, like you were saying, Parab, the platelets kind of get consumed, which leads to bleeding. Everything kind of gets consumed. All right, so good job with that one, guys. Let's kind of go on and see what else is going on. And then, in the upper right, as per my warning, we see this is a lap pad and a pad that was placed on her after labor, of which shows huge clots and lots of blood. Okay, so this is after surgery, after she's gone, to the recovery perhaps. So this is too much bleeding for that point. Okay, and we kind of had that impression anyway because of the 900 milliliters of blood lost, during the time. Okay, so now we kind of have the labs here. What really stands out to you guys before we kind of go through them? What stands out to you guys? Okay, low potassium, low creatinine, good. So the key's in the upper right-hand corner. So I want you guys to kind of get in the habit of seeing it like this, as I kind of, talked with you the last couple of times. So we know that the potassium is low, but my question is, this patient, so the the glucose is high. Good. Yeah, we know she has gestational diabetes. The MCV is low. Good job. You guys are all on point here. And perhaps the red gave it away, but you guys are right on point here. So my question for you guys is, we see her CBC, and I hope you guys did something that I did, of which was, you know, in a patient that's bleeding, we want to look at her H&H, her hemoglobin, that's one H, and the other H is her hematocrit. Okay, so what we kind of see here is normal. So that, you know, in my head, I'm like, why is that normal? Do you guys know why her H&H might be normal at this point? Good, Parab. You're absolutely right. So she lost whole blood, and what we see here with hemoglobin and hematocrit is, you know, it's a ratio. It's a ratio of the RBCs to the plasma. Okay, sorry about that, guys. My computer just went blank, so you guys are probably all like, what the heck? Okay, so as I was kind of indicating before my computer kind of went blank on me there, it's a ratio of the RBCs to the plasma volume. So as was kind of indicated in the chat, what happens here is when you lose whole blood, you're losing both RBCs and plasma. So what we're going to see is this ratio is going to change altogether. It's not one fraction that's changing over the other. It's both are changing. Okay. So that's why this H&H is normal. And sometimes it takes several hours after an acute bleed for it to kind of equilibrate, especially when you make up for that, that volume deficit when you give IV fluids. Okay. And then my next question for you guys is, what's the next test that we absolutely need to order? Think about the blood loss and think about kind of the treatment. Good, Josh. Perfect. Yeah, we want to determine her blood type. Do we know what this test is called specifically? It's kind of two tests really combined in one. Type and cross. Good. Yeah, so the type, what the type of the type and cross, what it is the type is determining her blood type. So as you guys may know your own blood type, there's A, B, and O. The positive means that they're positive for the D antigen. And then the cross is the cross match to look at the antibodies. And what we are really trying to do is make sure that there is no you know, antibodies that would react with the patient's cells. So that's what we're doing. And then as we see here, somebody very wisely in one of the previous slides indicated that we should ask her if she has any coagulation problems. Well, she wasn't able to respond to us, but we got the coagulation studies, and right now they're okay, which is very reassuring to us. Okay. Anything else? Any other questions you guys have, or any other labs that you guys want to have drawn at this point? What do you guys think? Nothing, huh? Okay, so CBC. So we did have a CBC canon. Good suggestion there. We did have a CBC here, of which was normal, including the H&H. Oh, and then, you know, we did kind of over the CMP here, so I'm glad I kind of went back. The one thing that is fairly obvious here is the creatinine is low. Is this normal or is this abnormal? Okay, so a few of you said abnormal, and you would be right to say that in somebody of whom was healthy. If I went and drew this lab on you guys and it was a little bit low, I would say that's probably abnormal. But the thing that we're looking at here is we're looking at a postpartum woman, just very recently postpartum. She gave birth, you know, basically minutes ago. So in pregnancy, the GFR, the glomerular filtration rate, so how much you're filtering through the glomerulus, is increasing. Therefore, the creatinine gets cleared faster. So this is a normal value for her. And what we're looking at the creatinine at this point for somebody who's bleeding is this: if this skyrockets, that if this went up and, you know, was super high and we saw a creatinine of 2 or something, we would want to be very concerned that due to her blood loss, she's going into renal failure. Okay. Does her shock not drop her GFR, or is that effect outweighed by the pregnancy-related increase? So, you know, she may not compensate that fast, is the problem. If we checked her lab the next day, then perhaps shock could play a role. But this is probably, you know, what we're looking at now is probably compensation from the pregnancy. Okay. All right. So her potassium is low, guys kind of pointed out, but otherwise, we got her type and cross, so we're ready to move on here. So my question for you guys, and you can mark it as you did with the annotation at the beginning, do we need imaging on this patient? Should we be getting imaging? What do you guys think? Okay. So a lot of you guys are saying yes. Some of you guys are putting yes in the chat. And you guys are right. You know, in the problem with this is there's no like algorithm for this that says absolutely get imaging, don't get imaging, you know, yes or no. It depends on the patient in front of you. If this patient is bleeding acutely, we want to find the source of the bleeding, and maybe that what the patient is presenting in front of us, you know, maybe an ultrasound is necessary. But in this instance, we certainly can, and you guys are absolutely right. And so what we're looking at here with this image here is we see the uterus is a little bit enlarged. Got my pointer here. And so what we see is this uterine cavity here is pretty enlarged. You know, same here, the arrows are showing you the uterus is enlarged. So you guys, good job with this one. Let's keep it moving here. And here's our tissue analysis. And does anybody have any kind of ideas here? What are we looking at? Good, we're looking at the placenta. Good job, guys. And is this a normal placenta or is this abnormal? What do you guys think about that? No idea. Emily says no idea. That's okay. This may be the first placenta that you guys have looked at. This is normal. Okay, so either for those of you that said normal, and sorry to pick on you guys, you smart ladies out there, Catherine and Sarah, what do you guys think? And the note earlier said it was normal for vascularity. Good job, Harley. She's very keen on details. So you guys are right. Why do you guys think it's normal though? What about this picture normal placenta to you? Good, it appears to be intact. The vessels look healthy, intact. Good job, guys. You guys are all right and you're spot on. So what we're looking at here basically is if we look at this placenta and we find that, you know, a piece is missing, like maybe it's kind of cut off here, and these vessels, what we see is they kind of run to the edge of the placenta. That's abnormal. So we know that if the vessels run all the way to the edge, we might be missing something here. And that can be a cause of bleeding. If there's still tissue, still a part of the placenta in the uterus, that can certainly lead to a problem, okay? And can cause bleeding. So good observations, guys. You guys are right on point with this. And you're doing, you know, far better than I thought you would with this very, very challenging topic, I think. Okay, so what differential diagnosis do we if you remember here, on her abdomen exam, which I don't think we kind of discussed, which we certainly can, is a diffusely enlarged and boggy uterus. Keep that in mind, okay? But we're getting to the point where we got to figure out what's going on with this woman. She's, you know, pretty sick. She's bleeding. She's losing blood. What's our first differential diagnosis? What do you guys think? Throw some things out there. So you can describe an abnormal placenta, and I have an example for you later, Emily, so you'll get a visual. I'm a very visual person. What you'll see is kind of a piece missing, or you'll see vessels kind of traveling to the end, but it might be clear that there is a piece of the placenta missing. Harley, boggy means kind of like almost floppy and kind of enlarged, okay? Poor muscle tone in her uterus. Good, Parab. You're right on point. Damage to the uterine lining. Yeah, we can certainly consider something like that. Good job, guys. Anybody else? What do you guys think? Can we rule out retained placenta? What do you guys think? Yeah, we can. You guys are right. We know that the placenta looks good. The vascularity looks good. Good. So one of you guys had said this, and I think this can be, you know, absolutely our number one, uterine. And we'll talk a little bit about this, but this is basically when the uterus, you know, because of certain risk factors like gestational diabetes, like having a macrosomic baby, leads to kind of stretching of the uterus, and then it doesn't contract back down to its normal size. So that leads to that enlarged boggy uterus. And when the uterus kind of is enlarged, the spiral arteries that go to the uterus are not contracted back down. So there's a source of bleeding that's because of the dilation of the arteries that's leading to excess bleeding. I hope that kind of is coming full circle and making a little more sense now, okay? So hemorrhagic shock or placenta previa, yeah, you guys, that's a very, very good differential, absolutely. So, and the way we can kind of justify this one is it can be most likely given the soft boggy uterus on examination. We also got an ultrasound of which showed that kind of diffusely enlarged uterus. What do we think is number two, guys? What do we want to consider for number two? So we can also consider trauma or lacerations. Have we completely ruled this one out, guys? I know we took a look with the speculum and we said that there was blood clots. We said that there was, we said that there was no lacerations on speculum exam, but does this rule out lacerations in general? No, it doesn't. Yeah, you guys are right. Something may be hidden. Good, yeah, and could have been somewhere else the speculum couldn't visualize. You're absolutely right. And what we see with the speculum is when we put the speculum in, we're looking right at the cervix, and we see it's dilated because the patient just gave birth. But you're right, there could be something going on with the uterus or where the speculum couldn't see. So yeah, that's why I think we should certainly include this for our differential number 2. Okay, it is less likely given the physical exam findings, but we can't rule it out completely. Okay. Off the top of your head, guys, what's one common cause of a laceration that we make? Do you guys know? Close. Dilation. Close. C-section, yeah, absolutely. I didn't think of that one, but we as in providers, absolutely, Josh. Sorry, I didn't clarify that. So the rupture of membranes, there can be bleeding because of it. It shouldn't be to this extent, though. Good job, Megan. That's what I was looking for, episiotomy. That's exactly what I was looking for. And that is one that we make. So, there could be a chance, due to just missing it, that we forgot to repair an episiotomy laceration. So, we definitely want to take that into consideration. The next thing we can consider is a coagulopathy. And this is certainly less likely given the normal labs. And then the next one, retained tissue, we kind of have ruled this out. So it's lower on our differential. And episiotomy is where you kind of cut, you make a laceration to allow the baby's head to come out, basically. So it's a kind of self-created laceration to allow the baby's head to go. Okay. And then the other one that we can consider is a uterine rupture. The other where the kind of uterus, basically ruptures inside of the peritoneum. This is less likely as well due to the fact that we had an ultrasound that showed the uterus intact. But, we put it on our differential anyway, because these are serious things we don't want to miss. The other thing is uterus inversion, where the uterus, births itself, it comes out. But we looked on exam, we didn't see a uterus out. So I'd even put that on the differential. That one is, fairly obvious. Okay. All right. So up here, we're going to talk a little bit about the assessment and plan. We're going to talk about the treatment of uterine atony. Let's see here. The first thing that is sort of on our assessment here is uterine massage. And you may be looking at this like, massage, what? And it's, it sounds exactly like it is. The uterus needs a little love too, and it's just feeling a little left out here, and it needs to be basically stimulated in order to contract back down again. And that's exactly what we're going to do. Okay. So the picture in the upper right hand corner demonstrates just that. Okay, so that's what that picture is showing you. Basically what we're doing there is we're inserting a hand or a fist and basically massaging the uterus in order to stimulate it to contract back down. And this kind of can relieve some of that bogginess. Poor uterus. I say that too, but yeah, it just needs a little bit of love. And the thing about this is, and it's pretty incredible, I think, is most of the time uterine massage is very effective at improving the uterine atony. And then, the next thing that we're going to talk about here is We're going to talk about giving medications, you know, if it doesn't work, if uterine massage doesn't work, or in addition to it as well. So we can consider that as also. So there are a few medications that we want to consider, of which are oxytocin, which may sound a little paradoxical to you guys because we know that oxytocin is a risk factor for uterine atony in the first place. But what we're doing here is after uterine massage, basically the oxytocin will allow the uterus to sort of contract back down. Okay, so we know that before it's kind of soft and boggy, and basically what we're doing now is having it sort of contract back down. Okay, so other medications that we can consider here are, sorry about that. We can also consider methyl ergonovine. We can consider prostaglandins. That's what PGF2A is, like misoprostol. And then we can consider tranexamic acid. It basically is a medication of which can increase clotting. And then something that we want to consider basically as last line, as you know, our last ditch effort is hysterectomy or uterine artery embolization or ligation. The uterus is supplied by the uterine arteries, of which are branches off the internal iliac arteries. If you remember this from anatomy, if you haven't taken it, look this up later. But if we embolize that artery, if we block it off, then the uterus doesn't have its blood supply to bleed. Okay, if we take the uterus out, it can't bleed. If we ligate that artery, if we put a suture around it, it can't bleed. So these are basically, you know, final efforts if we cannot control this bleeding otherwise. But as I kind of indicated to you before, the uterine massage is fairly successful at this. Okay. All right, and then the other thing, as we kind of indicated by getting the type and cross, is we want to transfuse 2 units. We want to trend that H&H, we want to watch it, and we want to give her oxygen by mask, okay? And then the other thing, well, in addition to the RBCs, is we want to give her 2 large bore IVs, at least 18 gauges at the AC or higher, okay? And then finally, we want to give her IV fluids to increase that that volume, her intravascular volume, and vasopressors, which will increase her blood pressure, okay, like norepinephrine. Okay, so we're finally to the pathology here. And a lot of, you know, what I'm going to talk about here is going to be in this chart. So when we think of postpartum hemorrhage, what we're really considering, this says, this is from the American Academy of Family Practitioners, AAFP. They say 500. I think they're referring to really a vaginal delivery here, you know, which is okay. As we kind of talked about before, 500 for a vaginal delivery, 1,000 for 1,000 cc's for a C-section, or 1,000 regardless of the type of delivery, okay? So that's how we define postpartum hemorrhage. And then we want to consider the 4 T's, okay? Tone, which is the big one that we just talked about here, like uterine atony. So soft, boggy uterus. So it's big and kind of floppy, basically. Trauma, we want to consider lacerations, so episiotomies, lacerations due to, you know, maybe if the baby's head got stuck and we use forceps or we use vacuum delivery and we kind of pulled the baby out, that can cause a laceration as well. Then the 3rd T is tissue. We want to consider if placental tissue is kind of left behind. And then the last T is thrombin. We want to consider sort of coagulation problems, okay? All right, so then, you know, each of these different types of causes of postpartum hemorrhage, each has its own unique treatment. Okay, so we'll talk a little bit about that in the end, but basically the whole point of this is the whole point of this is just to pinpoint what the cause is so that we can sort of, you know, pinpoint the specific treatment as well. Can you explain what the causes of uterine inversion? Absolutely. So uterine inversion can be caused by often decreased tone of the uterus, one, but one common cause is when, so as you can imagine, you deliver the baby is still kind of attached to the placenta, which is, you know, loosely adherent to the uterine wall. And when the baby's delivered, the cord is still attached. So what we do is kind of, you know, give a little bit of traction to the umbilical cord. And sometimes if you pull that umbilical cord too hard, the uterus flips out and it's still attached to the placenta. And that comes along really with problems of placentation. If the placenta is, you know, too tightly adhered to the uterus, and then you pull on that, the uterus can kind of flip out. Okay. Is placing balloons no longer recommended for these patients? In terms of bleeding or in terms of, it can be, you can tamponade. It's not common in terms of, you know, when we think of these certain types of postpartum hemorrhage, primarily because it's very temporary. So it's kind of a temporary measure and may not really stop that bleeding. Okay. All right. So let me clear all this, and we're going to talk about, you know, all of these different causes here in a minute as well. Okay, so uterine atony, as we kind of discussed, and here's a picture to the upper left. You don't really need to see the words. I know it's rather difficult to really discern. I tried to search for a bigger picture of it, but I couldn't find one. But here, what we're looking at here is, this is atony, and this is normal up here on the top. And as we can see here, when the contraction of the uterus, when it contracts down, these spiral arteries, these arteries here in the middle, get clamped down, and they're not allowed to bleed. And then in the second picture, the one on the bottom, if the uterus doesn't contract down, if it's kind of lazy and floppy, those arteries are allowed to be open, which causes bleeding. Okay, and that's exactly what the pathology is of this of uterine atony. And then what we're really looking at in terms of the risk factors are things that kind of distend the uterus. So multiple gestations, whether that's having multiple kids or having twins, perhaps. A big baby, and remember our cutoff, that's 4,500 grams. And then polyhydramnios, there's a few causes of that. We talked about a couple being gestational diabetes or intestinal atresia, where the baby can't swallow the amniotic fluid. So inadvertently, there ends up being more in the cavity. And then other ones is when the myometrium part of the uterus, the muscular part of the uterus, gets tired. So either there's rapid labor or prolonged labor, perhaps, or other things we want to consider is chorioamnionitis, which is infection of the amniotic fluid, or endometritis, which is infection of the uterus itself, or abnormal contractions. Okay, and then obviously with trauma, we want to consider lacerations. So if there was a forceps delivery, like I indicated before, if the baby, you know, you can see baby, you just need to pull baby out. We can use forceps or vacuum delivery, but both of those things can cause lacerations to mom. Okay, or episiotomies. And then tissue, we want to consider retained placenta, so abnormal placentation. Okay, and then the last one is hypercoagulable state. So pregnancy itself is a hypercoagulable state, but we want to consider other ones like factor V Leiden, you know, other things. We want to consider DIC too. okay? And then here, this picture on the bottom, a sort of brief introduction to sort of placental disorders is placenta, basically the normal placenta should kind of attach to the endometrium, okay? And then in accreta, it kind of goes a little bit too deep. So it basically is abnormally implanted. And then in creta, the way I remember it is it goes into the myometrium, and then placenta percreta. This is one of the bad ones because it goes all the way through, and it can even invade nearby organs like the bladder. Okay, so that's a one to certainly look out for. Okay. All right, and then for diagnosis and evaluation, we talked about this sort of extensively, so this will be an easy slide for us to go through. But remember our 500 for vaginal delivery, 1,000 for C-section, and our patient, when they present, after delivery, might be lethargic, altered mental status. They might have hypotension. They might have tachycardia, because if your blood volume is low, your heart rate has to increase in order to make up for that, to kind of increase the cardiac output around the body so that your critical organs like your brain can get increased nutrients, oxygen, etc. We might look for a soft, boggy uterus, which would indicate to us that that's atony. We might look for lacerations, which is indicative of genital trauma. We might look for a missing placenta that could tell us that there's retained fetal parts. And then for DIC and coagulation problems, we might look for blood oozing from the IV site and petechiae, okay? And then our labs that we want to look at, H&H, we want to see if there's anemia, but we want to remember that the H&H might take several hours to kind of reflect on this, because losing whole blood alters that ratio of red blood cells to plasma volume, okay? CMP, we want to look at the electrolytes. Coagulation, obviously look at the PT, PTT, two kind of branches of the coagulation cascade. We want to look at the lactate to see if there's any tissue ischemia. We want to look at the BUN and creatinine to see if there's any problems with the kidneys. And type and cross, we want to make sure we know what the type and cross is. Does anybody know how long is a type and cross good for? Is it good for life? You get a type and cross and you say, all right, your type is A positive, and you're good to go. It's on your record, you're good, we can give you that kind of blood. What do you guys think? After each pregnancy? Close. You definitely have to get it again. Does it depend on RH factor? So that's like a whole nother discussion. But it certainly can change, yeah. So the type part would change the same, but the cross part could change. Yeah, you're absolutely right. And so what I was really getting at is a type and cross is really only good for 72 hours is what we look at, okay? Each hospital admission, we want to get a new one. It doesn't matter what they're like last time, because if you transfuse blood, certain parts of their blood can change, okay? All right, and then a quick word about complications. This patient may go into hypovolemic shock. Some organs can shut down, like the kidneys, causing acute tubular necrosis, myocardial infarction, problems with their heart, and pituitary infarction. This is called Sheehan syndrome. So what happens with Sheehan syndrome is you get an infarction of the pituitary, leading to decreased hormones. So what you see afterwards is a mom loses a lot of blood and then comes in and cannot breastfeed. They haven't had a period for a lot of months. They have hypothyroidism. So anything that's kind of produced by the pituitary ends up, being low because the pituitary has infarcted. You could also get a dilutional coagulopathy, so you can get a coagulation problem. And as you can imagine, this can be fatal, so it can lead to death. In a cross test, what antibodies are we looking for? So Kevin, we're looking for a lot, actually. There's a lot of antibodies, a whole panel of them that's being tested for. Some are more common than others. You know, there's Lewis, Duffy, there's Kell, there's a lot of them. So if you're interested, Google it and kind of look at that panel to see all the ones that they test for. There's a lot, and it kind of differs from patient to patient, okay? And we want to make sure if they, you know, have the antigen, we're not giving them blood with the antibody, because then it'll attack the red blood cells. So that's the whole premise behind that. Okay, guys, so I have a few questions for you. I know you guys enjoyed this, and I know that I have gone over a little bit over 8 now due to my computer difficulties. And if you have to go, I totally understand. I do have some questions for you, and I'm going to start the poll here. Let's see. So this is a name the hemorrhage question. So this is a 33-year-old G3P2 female. She's presenting with oozing of her IV site following a vaginal delivery. Labs show a decreased platelet count and fibrinogen. You guys are doing great so far. So I'll give you guys a couple more seconds. A few of you have yet to answer here. All right, so I'll stop it there. So most of you guys got this one. Perfect. This is exactly what you guys indicated. This is DIC. So it looks like due to the low platelet count, the low fibrinogen, we have a consumptive coagulopathy. So good job on this one, guys. We see a little bit of petechiae in this image as well. So good job with this one. Let me relaunch this so you guys can get started if you're fast readers. So this is a 44-year-old female. She's evaluated on the L&D floor for postpartum hemorrhage. She's lost an estimated 1,050 blood following the C-section after arrest of the second phase of labor. The examination shows a soft, enlarged, and boggy uterus. I hope every single one of you guys that is still with me gets this one right. I think you guys will. All right, guys. So for sake of time, if you guys aren't in, sorry. Let's see here. So 94% of you guys said uterine atony, and you guys are absolutely right. So she had a prolonged labor. She was in arrest in the second phase, and she ended up having an enlarged sort of boggy, soft uterus. So good job. This is atony. So when the uterus kind of is puffy, sort of swollen out. Okay. Okay, so the next one, let me stop sharing here and relaunch this for you. So the next one is a 32-year-old female. She's presenting with increasing frequency of contraction. The cervix is maximally dilated. This is 10 centimeters, by the way. Though the physician proceeds with forceps delivery due to prolonged second phase. Following the delivery, there's an estimated blood loss of 750 milliliters. The patient demonstrates signs of altered mental status, hypotension, and pallor. So what do you guys think? I'll give you about a minute so we can keep going. You guys are doing great. So think about the mechanism. If you guys are in between or haven't answered yet, think about the mechanism here of the delivery. All right. So 82% of you guys said laceration to the vagina. Okay, so what do you guys think? What was the sort of thing that may have caused the laceration here? The forceps. Good job. Good job, Harley, Ronald, Emily, Megan. You guys are all right. The forceps. Yeah. If they said, changed out forceps for vacuum, same thing. If they said we had to make an episiotomy laceration here, same thing. Okay. So good job on that one. Let's see. I think I have two more for you, and this will really benefit you guys because you may see these questions again on the quiz in order to get credit for this. So kudos for you guys for staying after after the time and watching this. Okay, so let's relaunch this for you guys. So this is a 41-year-old immigrant who presents to the ED with increasing contractions and cervical dilation. Following delivery with extensive blood loss, the patient appears lethargic and suffers a syncopal episode. Examination of the placenta reveals the following. So I'll give you guys a few seconds. Good job. You guys are all doing great. All right, let me share this with you guys. 94% of you, great job, said retained fetal tissue. And you're absolutely right. So Emily, I know that you asked, what does a normal placenta look like? This is an abnormal placenta. Sometimes it's nice to know what's abnormal to know what's normal. So this is certainly abnormal. What we can see here is this is missing a part, we're clearly missing a part here. So when we pull that out and we see a part's missing, the residual bleeding could be because of that retained tissue. Okay, so good job with this one, guys. We almost got 100% on that one. That's like my ultimate virtual rounds goal, to get you guys at 100% for this. All right, so let me go on to the next one here. All right, so I have another warning sign for you, for you guys, for just so you guys don't get, super impacted by the next slide. But without further ado, so this is a 44-year-old female. She suffered a 1,300 milliliter blood loss following a vaginal labor augmented with oxytocin. Rapid examination reveals this. So let me relaunch this for you guys real quick. I'll give you guys a few seconds to answer this one. Good job, guys. I know there's a few of you out there that have yet to answer it. All right, so I stopped it so that we stayed at 100, but I'll do it that way. Good job, guys. This one is hard to miss. If the uterus is kind of come out towards you, it's literally waving at you. This uterus is inverted. Okay, if you guys, what do you guys remember? What is a risk factor for this? If we see the uterus is inverted, it kind of has birthed itself. What causes this? Excess pulling on the cord. That's right. Yeah. So if we're putting a lot of traction on that umbilical cord, and the placenta is too firmly attached to the uterus, and we pull, it can come out. So good job. A lot of you guys had this teamwork effort to answer that. So good job. You guys are paying attention. Good. This is the last question. So I did add kind of this cartoon about ectopic, so you guys can kind of look back on it. But basically, an ectopic can cause bleeding, but this usually is caught kind of beforehand. So it can cause sort of abdominal pain. It can cause abnormal bleeding, and usually what happens is the serum HCG is high, and then we do a ultrasound and we're not seeing anything. And the most common site of this is in the fallopian tube, obviously. That's why it's called an ectopic pregnancy. But the most common site is the ampulla of the tube. Okay. All right, so let's keep it moving here. I think I have one more slide for you guys here. All right. So last slide. So as we kind of talked about, if we're dealing with atony, we want to do a uterine massage. And as someone had indicated, poor uterus, it's absolutely right. Then we want to consider medications otherwise, and then surgery as kind of this last ditch effort if we are unable to control it with other mechanisms. Then we want to consider trauma like lacerations as a result of forceps or vacuum delivery. And then for treatment for that is we want to correct that defect. We want to correct that laceration. Then for retained placenta, we want to do a D&C, which is a dilatation and curettage. You want to take tools and kind of scrape out the tissue of the uterus to prevent bleeding and to get that retained tissue out. And if that's unsuccessful at keeping that bleeding at bay, then we want to do a total abdominal hysterectomy. That's what TAH stands for. So just take the uterus out and its source of bleeding if we can't control it. Because as you can imagine, we can lose an incredible amount of blood as a result of a postpartum hemorrhage. Okay, and if there's a problem with clotting, then we want to consider replacing factors, replacing platelets, fibrinogen, in the way of cryoprecipitate or fresh frozen plasma. Okay, and then if the uterus is inverted, we want to manually replace the uterus. So we want to put it back and give oxytocin to kind of contract that uterus down into place. Okay. Oh, so I do have one more question for you guys, just a last kind of question here, similar to the one we had. So let me launch this for you guys. So do me a favor and just fill this out as honestly as possible. And I do appreciate you guys kind of staying after. I know I was a little bit of time over today due to my technical difficulties here. All right, guys, so the majority of you guys are in here. And it looks like a lot of you guys at the beginning kind of said you knew nothing or you knew a little. And the majority of you guys, 63% of you guys said, I know a considerable amount. I am very grateful to have your guys' attention and time this evening. I hope that you really learned a lot about this topic. I know this was, through virtual rounds, one of your first exposures to OBGYN, and hopefully we can do some more of these if you guys are interested. But if you guys have any questions at this point, I'll stay on for a little while here, and you guys can ask any questions that kind of are on your mind. But otherwise, be sure to fill out that 10-question quiz at the end. You guys will kind of find that a few look familiar. So hopefully it's not too challenging for you. And we'll be back here next week, the 28th, for an emergency medicine case. So if you have any questions, I'll stick around for a few minutes. But otherwise, thank you guys for coming. I'm grateful for your time.